We start with our next lecture, which is on fetal biometry and fetal anatomy. May I invite Professor Papageorgiou to give this lecture to us.
Thank you so much for coming today to this ISUOG basic training. And I'm going to be giving some slides on basic fetal biometry and assessment of the fetal anatomy. Please stop me if you have any questions. These are the learning objectives. At the end of the talk, you're going to understand the measurements that we take in obstetric ultrasound and how they are used. You're going to understand how we estimate gestational age in all the different trimesters. And we're going to look at what normal fetal anatomy looks like and some common abnormalities. We're going to cover the topics of estimating gestational age, using fetal measurements and also fetal size, what the standard biometry is that we should be taking, and we're going to talk through the correct anatomical planes for measurement and assessment of the head, abdomen, and leg. We're going to look at some common abnormalities that I've listed here. Key questions that we want to answer as part of this is: how should we assess gestational age, and how does this differ in early, middle, and late pregnancy? What are the key features of the sections that we want to look at to measure those basic measurements: head circumference, BPD, abdominal circumference, and femur length? And I'm going to use the abbreviations after this slide, okay? So I'm not going to use the whole word anymore. I will use HC, BPD, AC, and femur length, and how we can combine these measurements together in an estimated fetal weight, or EFW. And the final key questions are: what are the key abnormalities that we need to exclude by looking at these standard planes? What are the major differences in ultrasound between these important abnormalities, abdominal wall defects, and also mainly urinary tract obstruction? So I cannot cover in a single talk all abnormalities of the fetus, but we're going to look at some key important abnormalities. So, estimating gestational age. How do you estimate gestational age in your settings? Anyone? LMP? Yeah? So most people estimate gestational age by LMP, but in order to do that, the mother needs to be sure of when her last period was. She needs to have a regular cycle. She needs to not have had a recent pregnancy or a recent breastfeeding. And we know that in at least 50% of mothers, one or more of those are not completely accurate. So many women will not recall when their last menstrual period was accurately, or they may not have regular cycles. And in particular, in those circumstances, we can use ultrasound to measure the size of the baby, and by measuring the size of the baby, estimating the gestational age. Now, you can do that very, very early, but the problem is when you do the scan very, very early, the structures are very small. So if you just make a small error in the measurement, you would make a big proportional error in the gestational age. So generally, we don't recommend to use the sac diameter, mean sac diameter of the gestational sac. We don't use that to estimate gestational age. The best time to estimate age is based on the crown rump length of the baby. The crown rump length is from the top of the head of the baby to the baby's bottom, and I'll show you some pictures. And at this gestation, the crown rump length is between about 32 millimeters and about 85 millimeters. You can measure the crown rump length earlier, of course, but again, because this is an earlier gestation, it's not so accurate. And after 14 weeks, the baby gets very curled up. Then measuring the crown rump length becomes less accurate. So after 14 weeks and up to about 24 weeks, we try and measure fixed points in order to better estimate the gestation. And the best is using the head circumference in combination with the femur length. Or if we can't get one or the other, we're just on one of the two. And after 24 weeks, it becomes very inaccurate to estimate the gestational age based on ultrasound. Do you know why? Why is it inaccurate at 32 weeks? Why is it so inaccurate to estimate the gestation? Yeah, exactly. So babies, very early in pregnancy, babies are very close together in size, but the later you go in pregnancy, the more variation there is in the size of the babies. Sorry. So if you see a baby at 32 weeks and it's growth restricted, you would underestimate the gestational age. Or if the baby was a big, fat baby, you would overestimate the gestational age, which is why in the third trimester you need to be very cautious. So, this is an image of the crown rump length. Good image? Bad image? Someone says good. What are the criteria that we are looking for? Shout them out to me. What criteria are we looking for? What are we looking for to say this is a good image or not a good image? The baby needs to be straight like a soldier. Straight like this. Well, it's kind of the legs are away, but straight. So the baby is not like this, and it's not like that. Yeah? And the way you can tell that is because if you look at the chin, you can see some fluid there between the chin and the chest. Can you see that? A little bit of fluid there between the chin and the chest. If the baby is very curled, then you lose that fluid between the chin and the chest. The baby is in a neutral position, as we call it. And the calipers here are placed correctly on the top of the head and at the bottom of the bottom. And also it's a median cross-section through the baby, because we can see the bladder of the baby, we can see the profile of the baby. So it's a good sagittal view of the baby. So these are the criteria to properly measure the crown rump length. A midline sagittal section of the whole baby. Right through the middle of the baby. You have a neutral position. The baby is like a soldier, straight. Not overextended and not curled up. And in order to judge that, you see some fluid here between the neck and the chest. A little bit less here at the bottom. Can you see that? So this baby is more curled, so you will underestimate the crown rump length. You need to see the points, the ends clearly, and the baby should be more or less horizontal to the ultrasound beam. So not upright, but horizontal. And in all of the slides, you will see that we have a lot of magnification. So the baby should fill the screen. Don't send me a picture with a tiny little baby right in the middle and all the empty space around. Use your ultrasound to magnify and see everything. Don't have a little corner upstairs. Okay? And then the calipers, of course, need to be placed correctly. Now, for the correct caliper placement, you need to make sure that you go to the top of the head, like this yellow line. Can you see the yellow line? All the way down to the bottom. And this red one is giving an example of an incorrect measurement. You can see here you're missing some of the baby's bottom, and you're not really measuring the maximum distance. So you want to measure the maximum distance. Okay? Any questions on that? How to measure the crown rump length? You do this? Do you do ultrasound? Yeah, you do the crown rump length. Sometimes it's difficult to get it, and the baby is kind of all like that, and you take a coronal section sometimes, where you see the two. That's bad, because you miss part of the baby. Yeah, so you must try and get a sagittal view, if at all possible. Now, in ultrasound, it's really important to remember that we can do a fairly basic examination of the baby by taking a series of cross-sections through the baby, a series of axial views. Look at this video. Okay, I'm going to show you this video. All I'm doing here is I'm taking cross-sections from the bottom, from the head, through the chest, through the abdomen, all the way to the bottom of the baby. Okay, and then I turn my probe a little bit just to look at the legs and the hands separately. But most of the anatomy you can see in just a series of cross-sections through the baby. So from the cross-section through the head, cross-section through the face, cross-section through the chest, the cord insertion, the abdomen, the bladder. Okay? So just by moving the probe upwards, as I showed you in that little video demonstration, you can get the major planes that you need to get. We're going to start with the head, and this is a standard measurement of the head circumference. So you measure the head circumference in this view, with a cross-section like this, through the head of the baby. Okay, from the forehead to the back of the head, and it's the maximum diameter. Now there's some landmarks we're going to be looking for when we measure the head circumference. Who's going to tell me some of the landmarks? They're on the image, but I haven't labeled them on purpose because you're going to tell them to me. Tell me some landmarks. Anyone? Cavum, septum, pellucidum. So can you see this white line in the middle? This white line in the middle separates the right and the left side of the head. And that line is broken. Can you see the little break? That is called the cavum, septum, pellucidum, the CSP. And that's about a third of the way along from the front to the back. Can you see that? So that's one of the landmarks. Some of the other things that I'm going to be looking at this image is the fact that this side of the head and that side of the head are roughly equal. It is symmetrical. Why is that important? Because if I take a cross-section through the head like this, it will be symmetrical. If I take a cross-section of the head like this, the right and the left side will not be symmetrical. And you can see the nice kind of egg-shaped size of the head there. So these are the criteria. Lots of words, but it's actually pretty straightforward. So we have a midline echo. This is a midline echo going from the front to the back. We have a cavum, septum, pellucidum, a third of the way along. You can see here the choroid plexus, and the ventricle. You can measure the ventricle as well, and we'll come back to that later, which is measuring the ventricle from inner to inner. But for the purposes of this image, we're looking at the head circumference, and I'm putting my calipers here on the outside. People often forget where to put the calipers. Imagine you have the baby in your hands, and you have a tape measure. Okay? That's where you put your calipers, on the outside of the head, as if you had a tape measure in your hand. That's what you're trying to recreate. Because in pediatrics, we also measure the head circumference, and that's exactly what we do at the same level. Okay. Which plane is this? Do you know the name of this plane? It's called the transventricular plane. Okay? It's a transventricular plane. The reason it's called transventricular is because you can see the ventricles. You can also measure the head circumference. In some textbooks, it suggests you measure the head circumference in the transthalamic plane, where you don't see the ventricles anymore. You see the thalamus in the midline. I have a picture in the next slide. Okay? We have done a study to compare the transventricular and the transthalamic plane, and the difference between the two is tiny. Tiny, tiny, tiny. It's almost the same. So, for practical purposes, I don't mind whether you measure it in the transventricular or transthalamic plane. The difference between the two planes is minimal and well within the error of ultrasound measurement. But it is good practice to use one measurement. Okay. So you can take the cross-section of the head at the level of the lateral ventricles or at the level of the thalami. Remember to put the head circumference on the outside like a tape measure. If you don't have the ellipse facility, you can also measure the BPD and the OFD, but you need to measure the BPD from outer to outer if you're going to calculate the head circumference. Yes? Otherwise, you're not calculating the head circumference. Does that make sense? And there's a formula that calculates the head circumference automatically for you, which is based on the BPD and the head circumference, which is written down there. Now you can use that head circumference measurement to estimate the gestational age, because we know that at different gestational ages, the head circumference is a different size, and by measuring the head circumference, you go to your lookup chart or this little graph, and you can plot the head circumference on the 50th percentile, and that will tell you what the gestational age is if the baby is an average-sized baby. Okay? Now, obviously, if you have signs that maybe the baby is growth restricted, or that there's an abnormality in the head, or something like that, then you must be very careful to allocate the gestational age based on the head circumference. Yes? Okay. So if this woman has come previously at 12 weeks and she had a crown rump length scan, and we now measure the head circumference, and we find a different gestational age, what are we going to do? Are we going to change her dates? No. Great. That's the right answer. Because a head circumference is a size measurement. Head circumference is a measurement of size, not a measurement of time, right? It's a measurement. So if at 12 weeks the woman was 12 weeks pregnant, and now it's 10 weeks later, she is 22 weeks pregnant. Whether the head circumference is big or small is an irrelevance. So always use your first reliable measurement to date the pregnancy, preferably the crown rump length. Once the gestational age is set, don't change it again, because that is when errors occur. That is when you make a mistake because you assume that the gestational age is different, whereas in fact maybe there's a growth aberration of the baby. Maybe the baby is too small or the baby is too big. Yes? Agreed? Fantastic. So please don't tell the mother the baby is 24 weeks size. 24 weeks is a measurement of time, not size. If the woman is 22 weeks, the baby may be bigger or smaller, but that's what it is. Okay. So that's dating by head circumference if we don't have an earlier measurement. We can also measure the femur length. The femur length is pretty easy to measure. Perhaps, surprisingly, the femur length is actually one of the less reproducible measurements. It's not as reproducible as one might think, because it's a bony measurement. You think it's very clear, but actually, compared to the head circumference, it's less reproducible, the measurement. We measure the femur. It's a pretty straightforward measurement. You must make sure that you go from the edge to the edge. And you need to make sure that you rotate and you slide your probe until you have both ends of the metaphysis clearly visible. And you measure the longest axis. Now sometimes, when you get the baby's femur, you see like a little spike. You know that little spike that you can sometimes see? You don't measure that. Measure just the femur itself. That little spike is sometimes a ligament that goes and connects the femur, the muscles of the femur to the patella. So these distal femoral epiphyses or the spur artifacts should not be included. And it is useful to have the femur roughly horizontal to the ultrasound beam. A little bit like that is okay, but don't allow the femur to be upright, because your shadow from your ultrasound will hide the femur correctly. So we recommend usually that the measurement should be up to about 15% of the horizontal. Now when we calculate gestational age based on head circumference, like we said before, if we add another measurement, if we add the femur, we improve the accuracy of the dating a little bit. Okay? And you can do this using formulas. There's published formulas which tell you that this head circumference and this femur, and you add the two together and it gives you a gestational age. So it improves the accuracy by quite a few days. But there is an issue that you need to be aware of, which is that works when the two are roughly in agreement. If the two are very far apart, if the femur is suggesting that the baby is 16 weeks and the head circumference is suggesting the baby is 24 weeks, okay, then it doesn't work. Then you need to work out why is this big discrepancy happening between the two. So they need to roughly agree to be reasonably near the same centers. But if they disagree, please review your images, make sure that you've got the correct sections, that the calipers are placed correctly. If they're still not sure, if you're not sure, please repeat the cross sections, remeasure them. And if there's a genuine discrepancy, you need to be aware that this may be a problem. There may be a problem with the femur. Perhaps the baby has a very small femur because of skeletal dysplasia or another problem, early growth restriction. Or the head circumference may be small because the head is not normal. Yeah? So just be aware that you need to have the two roughly in agreement before you can use those for gestational age assessment. Is that more or less clear? Good. Abdominal circumference. So we take a cross section through the abdomen. Cross section through the abdomen, straight through the middle like this, and we measure how fat the baby's getting. Okay? Now we want some landmarks because the abdomen is quite a large structure to be sure that we're in the right place. One of the landmarks is the stomach, which is this black fluid-filled space here. And another landmark is the umbilical vein. Can you see it there? What would happen to that umbilical vein if I move downwards? What would happen to that black spot if I move down from where I am? It's going to move towards the front, yes? Because it's going to reach the umbilical cord, yes? So as I move down, that little black spot will move forward. As I move up, that little black spot will go backwards and upwards towards the heart. So by having it a third of the way along means that I'm in the correct plane. Does that make sense? So this is how it helps us, because that vessel runs diagonally like this from the cord insertion to the heart. I'll show you a cross-section of the baby like this so that it makes it obvious. This is the head of the baby, and this is the bottom of the baby. Can you see the umbilical vein there, traveling diagonally? Yes? So if I have the correct cross-section through the baby, then I see that little black spot there, and it's a short segment. Can you see that? Because I'm taking a short cross-section. So these are the criteria for a correct abdominal circumference. I want to be more or less circular. The stomach bubble is visualized, and we need to slide up and down in order to get the visualized stomach bubble. We want a short length of the umbilical vein, exactly as I showed there. And the kidneys have no business to be in this plane. The kidneys are lower down, right? So if you're seeing the kidneys, you're too low. You need to come up a little bit. Nor should you have the bladder visible, okay? Because that's clearly far outside the area. And as before, we need to make sure that we magnify. This is a third trimester fetus, and often you have these shadowing artifacts. Can you see this shadow there? So you need to maybe increase your gain a little bit in order to see correctly the edge there. Look at this cross-section through the baby, resulting in this correct cross-section here. So this is a correct one, right through the baby here. Number one, a short length of umbilical vein. Can you see that? Number two is a stomach bubble visible. If you angle your probe like that, can you see you get this long segment? Yeah? Because you're running along the umbilical vein like that. Can you see that? So that is an incorrect cross-section. Difference is small, but it is enough to make quite a difference in your measurement. So in order to get reproducible measurements, make sure that your cross-section through the baby like this, not like this. Imagine a salami. If you slice the salami at right angles, you get nice little round ones. If you slice the salami across, you get long strips, yeah? That's exactly what happens. So there we have the basic fetal measurements: head circumference, femur length, and abdominal circumference. Have you got any questions on the basic fetal biometry? Good. So we're using HC and femur length here for estimation of gestational age. We don't use AC for estimating gestational age because the AC is the one that changes most according to how the baby is being fed. Okay. Now again, like we did in the head circumference, we can fit an ellipse onto the AC, like we do here. And if we don't have an ellipse function, we can put two diameters. One goes from antero-posterior, so from the back of the spine to the front of the abdomen, and the other one has to go transversely. And these two diameters should be at right angles to each other. Okay, so you can move like this, but they both have to move together, not like that. Yeah, at right angles. Does that make sense? Good. And then the AC is calculated from those two diameters. Roughly, because it's roughly circular, you just fit it into a perimeter of a circle formula. Now the good thing of these landmarks is that these landmarks are pretty stable. So whether you measure the AC at 16 weeks, or at 19 weeks, or at 31 weeks, the landmarks look very similar. The landmarks you're checking for are the same: the stomach and the umbilical cord. Okay, of course the AC looks a bit different, and there's a bit of shadowing here, but the basic landmarks are the same. Now at 20 weeks or 19 weeks here, there's very little fat under the skin. Can you see that? And so the skin line is very clear. By the time you get to 31 weeks, the skin line is quite wide. And that's because there's this adipose tissue the baby's putting fat on. Again, remember your tape measure. Pretend you have a tape measure in your hand. People often ask me, do we go to the skin, do we go to the... So just imagine you have a tape measure in your hand. That's the easiest way to imagine. You can only go outside the skin of the baby. Oh. We've said this already. Once we've assigned the estimated due date or the gestational age, we are not going to change the gestation of this baby. Rather, we are going to use our fetal measurements to assess fetal growth velocity, the fetal size, so in the individual measurements, and we can also estimate a fetal weight. So, and there are many charts available that you can assess fetal growth on. So you plot your measurements and you see how the baby's growing. This is head circumference here, biparietal diameter, AC, and femur length. Okay, this is just one of the charts that we were presenting yesterday. Now, if I take you, sir, and I measure how tall you are, and I measure your head, and I measure your abdomen, I can kind of work out how much you weigh. Yeah? But it's not going to be as accurate as if I put you on a weighing scale, right? Because I have to estimate your weight from the measurements that I'm taking. And we can do the same with the baby. So we can estimate the weight of the baby by combining the measurements of the head, of the abdomen, and of the femur length, and we put it in a formula that estimates the weight. But please remember that this is an estimation, because the measurement of the head has an error, and the measurement of the AC has an error, and the measurement of the femur has an error. And when you do an estimated fetal weight, you are multiplying all the errors as well. Okay? So there is an error, and we know that that error is about 8 to 10%, but it's bigger in big babies and also in small babies. So the small babies, we tend to overestimate their weight a little bit. The big babies, we underestimate the weight a little bit. And the average babies, we don't do so bad, but actually the average size babies, we don't care so much, because really what we want to know is the extremes. So it's not a brilliant test, but it's a useful summary measure of the growth of the baby. Now you can measure the estimated fetal weight, and there are many different formulas to do that. You can do it based on the abdominal circumference alone, okay? Because the biggest determinant of the weight of the baby is actually the AC. Or you can measure the AC and add in the head circumference and the femur and potentially the BPD. And we get slightly different formulas for calculating the weight. The most established formula for calculating the weight is the formula by Hadlock, which was based on 109 women from Texas. And they calculated how to use the formula from the measurements to calculate the weight. Okay? There are two steps here. The first is you take the measurements and you calculate the weight using a formula. A second step is you take that weight and you put it on a chart. Do you understand the difference between the two? The calculation of the estimated fetal weight using Hadlock is pretty good. The charts of Hadlock are not probably so good, and there are different charts available as well. So this is how you calculate estimated fetal weight. And again, you can chart the estimated fetal weight on this chart. It allows you to track the overall estimated fetal weight of the baby. It's very important, especially when you're doing an estimated fetal weight, really to be careful how you place your calipers. So these are just two examples. This is a baby where the AC is slightly underestimated. You can see there that we're missing a little bit of the soft tissue, making the AC 310. The femur is also not measured very well, about 60. And this is more correctly measured. And you can see these big differences in the AC and the femur length. And these will have a major impact in differentiating the estimated fetal weight of this baby. And this is a little bit where the error lies. So one error is inbuilt in the fact that you're using a formula, but another error is our accuracy and our care when we take the measurements. So please do be careful when you take the measurements, especially for estimating fetal weight. Now, in a lot of settings around the world, a woman will first present in pregnancy quite late in gestation, right? And that is a difficult scenario for us to try and work out the gestational age. Because in the same settings where women come late is also where many women will have growth aberrations because of poverty and poor nutrition, etc. So we do need to beware. And we generally say that once you're above 24 weeks, estimating gestational age based on measurements becomes really quite unreliable. So you need to be very careful, because if you had an average baby that was 30 weeks gestational size, but if it was a small baby, it could be a small baby that measures 30 weeks. It's actually 32 weeks. Or the woman could be 28 weeks and the baby's overgrown because of diabetes, for example. Because of that, generally speaking, we should use biometry once a baby is quite large to assess the size and not so much the gestational age, and probably need to do subsequent examination to remeasure the same baby 3 weeks later or so, 3 or 4 weeks later, to see how the growth of the baby has continued. If the baby is growing along the line, then we can be more confident in giving her a gestational age if we have none at all. But if the baby is becoming slower, then we must be ultra cautious about estimating the gestational age. And the same is true if the baby is getting bigger. Does that make sense? So we look, by having 2 time points, how it fits on the growth curve. And this is the idea here, that we can assess on subsequent examinations. So here, if we have a head circumference of 300 millimeters, for example, the baby could be, about 28 weeks there, or it could be as much as perhaps 36 weeks. That is how wide the range is. which is why one needs to be very, very careful. Okay, so much for basic biometry and gestational age estimation. I'm going to spend about 10 minutes on basic anatomy and what looks normal and what doesn't. Is that okay?
Excuse me.
Mm.
I do have one question. When we do the biometries, right, if the HC, AC, and AFL is all equal and similar, but if the BPD, there is some discrepancy within the size, how reliable is BPD for the EFW?
So, in various studies, they have included or excluded BPD, and there's no absolute certainty, but it seems that it's better not to include the BPD, especially if you think about the BPD. If the baby is breech, for example, sometimes the BPD is quite small because the baby's head is flat like that. So the BPD is smaller, but the OFD is longer. The head circumference is maintained, but the BPD seems smaller. If the baby has quite a round head, the BPD is bigger, and this way the baby's head diameter, the OFD, is a little smaller. Again, the head circumference is maintained, it's the same. So the BPD does show more variability. And because of that, we are trying to encourage people to move away from BPD and towards head circumference.
So for the
But
EFW,
BB, and for the EFW too.
so it is
Yes,
not to include
correct,
BPD.
correct. But BPD has been such an established measurement for so many years, for so many people, which is why it's still being used. But I think it's a good idea to move away from BPD and move towards head circumference. Okay? Because the head circumference is less affected by positional aspects of the baby and by amniotic fluid differences also. Okay. Now, before we're going to decide whether something is normal or not, we're going to assess the position and the presentation of the baby. Okay? And we're going to know where is the right side of the baby and where is the left side of the baby. Okay? And this is my left side, not because my stomach is on the left, but because this is my left side. So don't assess the position of the baby based on what you expect to find in the anatomy. Do you understand that? Work out where the baby is. Is it lying like this? Is it lying like that? Is it looking down? Is it looking up? Where is the right and where is the left? Imagine yourself lying in the womb. That's the easiest way to do it. So you hold your ultrasound probe and you think about, this is the head. I'm lying like this with my head that way. We all do it. Okay? Don't be embarrassed to do it. I still scan. I have the scan in my hand and I'm doing this. Okay? And the woman thinks I'm kind of crazy. I'm trying to imagine myself in the womb and which way I'm facing. Okay? It's fine. Don't worry about it. It's important to do that because you need to remember which side is which. And that's important when we're assessing the fetal anatomy. And then we're going to take our axial views that we saw before for the standard measurements. And we're going to start looking at the anatomy of the baby. We're going to look at the head circumference. So if you just measure the head circumference, which we talked about already, by measuring the head circumference, we can start seeing some abnormalities, okay? And I've put the names on there for you, so you don't have to worry. But remember that in a normal head circumference, we're seeing the nice white line in the middle, and a third of the way along we have the corpus septum pellucidum, and we've got the ventricles here. What's going on here? The line is not there. Can you see it? These are the thalami, but the line stops. And the ventricles at the front, these are the two ventricles, the ventricles are joined up at the front. This is holoprosencephaly. Okay? It's a rare abnormality, but it's easy to recognize. It's a lethal abnormality, this. Okay? Not associated with postnatal life. Or you can have a much more mild abnormality of the ventricles. In here, you can see the ventricles are quite small. You measure the ventricles from the inside to the inside there. And here, if you measured this, this would be about 12 millimeters. So this baby has mild ventriculomegaly, which is not a problem. It just needs an extra examination, needs some more detailed assessment, a referral perhaps for karyotype, depending on the prior risk, etc. Okay? So these are some common abnormalities in the head view. I'll show you some more common abnormalities. Can you see this one here? You see that there's a gap in the skull bone at the back, and you have this bubble coming out. This is an encephalocele. So this is a break in the bone, or a failure to close the skull bone, and the membranes that surround the brain are coming outside. It's a type of neural tube defect. Think of the neural tube. The baby is like a plate in the early part of the pregnancy. It's like that. This is a baby. Okay? And then the baby makes a tube. It goes like that. It zips up and it zips down. And then it folds over. Okay? This becomes the head and this becomes the bottom. If this zipping does not happen properly, then you have a hole in the neural tube. You can get a hole in the neural tube. If it's at the bottom, then you get spina bifida. If it's at the top, then you get anencephaly, exencephaly, encephalocele. Okay? So these are neural tube defects. Which fruit do we think of when we look at this? Two fruit. Lemons. What other fruit is involved in spina bifida? Banana, yeah. Lemons and bananas. The way we screen for spina bifida is we look for lemons and we look for bananas. There we go. This is a lemon. Can you see the head is shaped like a lemon and has this little thing at the front? This is because this part of the skull is depressed. And at the back of the head, the cerebellum, which normally looks like a dumbbell shape, is pulled backwards, so you have this banana-shaped cerebellum. And this, looking at the head, not looking at the spine, just looking at the head, as a screening test for spina bifida, will detect the majority of babies with spina bifida. So this is what you get normally. You get the head with a nice midline, nice rugby ball-shaped head. And here you have, it's the other way around, but here you have a baby with spina bifida, a lemon-shaped head. This is a normal cerebellum. Can you see it? Cerebellum is a little bit lower than the head circumference, and it's tilted backwards. So this is your head circumference, and you tilt your probe backwards, and you see the cerebellum. This is the head circumference. You tilt forward, you see the eyes. You tilt backwards, you see the cerebellum. Okay? Rotation of the probe. And if you have an abnormal cerebellum, it looks like that, like a banana, and you have a spina bifida, which you will see every time you have a lemon and a banana if you look hard enough. If you see these signs, the baby has a spina bifida somewhere. Okay? Sometimes it's very small and you may need to look for it, but you will find it eventually. Okay, we travel down the baby. We've done the head, we come down to the chest, and this important view is the four-chamber view. And this is what I was talking about before. We know this is the left side of the baby, and we know this is the left side of the baby. There's a stomach, and just above the stomach is the heart. Okay? So stomach on the left, heart on the left. And the way I always remember it is you have the spine, and opposite the spine is the right ventricle. So always look for the spine, and opposite the spine is your right ventricle. Remember, the spine is right. Spine, right ventricle. Once you know where your right ventricle is, you can work out the rest. So right ventricle opposite the spine, left ventricle, left atrium, right atrium. Okay? But you need to make sure that it's on the correct side. The descending aorta, which comes up like this and then goes down, is also just to the left of the spine. Can you see that? Just to the left of the spine. There it is again, a little bit further down. Okay. So this is a four-chamber view. Normal or abnormal? Are you happy with it? Yeah? Yes, it's normal. Good. This is a normal four-chamber view. It's on the correct side. I'm telling you that because I've just scanned this baby a minute ago, and the stomach was there on the left. You can see 4 chambers. 1, 2, 3, 4. There's a spine. What's that chamber there? Right ventricle. Great. What's that white stuff in the right ventricle? It's called the moderator band. Okay? It's what appears in the right ventricle. You don't have it in the left. That little white stuff there near the apex of the heart is the moderator band. You can see the 2 atrioventricular valves. You can see them opening and closing nicely. And can you see that the valves are not exactly in the same place? They have a little offset. That is called the offset of the valve. And in the middle of the heart there is the cross, although it's not really a cross because the valves are offset. That's called the crux. And the septum is correct, and the axis of the heart is also correct. And the size of the heart is also correct. You can see here the descending aorta. Okay? It's a nice, normal heart. You can also assess the relative size, not just to the chest, but between the 2 sides of the heart. There's a crux right there in the middle. Okay? And there's the axis. Happy with that? Good. We continue our trip down the baby, and this is the abdominal circumference. So this is a nice normal abdominal circumference. What's going on here? Two big black bubbles instead of 1. Yeah? This is a so-called double bubble. It's usually due to an atresia of the duodenum, so you have extra. What else can you see on this picture that goes with that? See some additional fluid around the baby. Yeah? What about here? What can you see here? What's wrong with that picture? Compare it to the one directly above. Yeah, there's no stomach. What's that there? That's the umbilical vein. What's that structure there? It's a gallbladder. Gallbladder. Yeah? This is the left side of the baby. This is the right side of the baby. It's unfair because I'm not telling you which is the right and this is the left. But here is where you should have the stomach, so this baby has no stomach visible. What's the problem here? There's a stomach. There's the umbilical vein. What's the problem in that baby? There's some black stuff inside the baby. Yeah? Can you see that? And that's fluid. It's called ascites. So there's some acidic fluid. And here you have another obstruction of the bowel. So most of the things when you look at abnormalities of the AC is you look for abnormalities of fluid. So you have extra fluid or not enough or in the wrong place. Okay? Then we come a little bit lower, and if we come a little bit lower still, we see the insertion of the umbilical cord. Can you see it there? Insertion of the umbilical cord. And as we slide down from the abdominal circumference down to the bottom of the baby, we come across this view. Remember to maintain a cross-sectional approach, and you can see the cord inserting just above the bladder. Okay. So I know I'm overrunning. I'll be 3 more minutes. This is another cross-section through the baby at that same level of the umbilical cord. What is the problem here? Does it look the same as before? Do you see the umbilical? No. There's something sticking out of the umbilical cord. There's the umbilical cord. Something sticking out into it. This is called exomphalos, okay? Or omphalocele. This is another one. This is a baby here, and there's all this stuff outside, and if you look at the cord insertion again, it doesn't look normal. This is gastroschisis. Excellent. I don't know what I'm doing here. This is brilliant. So, omphalocele or exomphalos, same thing. Omphalocele, exomphalos, 2 names for the same thing. You have an abnormal cord insertion where you can see the cord inserting at the apex of the deficit, of the defect here. And it can contain the bowel, it can contain the liver, and there's a membrane that covers it. Okay? As opposed to gastroschisis, where there is no membrane covering it. The bowel is just floating around. So you have a normal cord insertion, and then the defect in gastroschisis is just to the right and below the umbilical cord, and you see the bowel floating around. Bonus question, which of these two babies has trisomy 18? Which one is associated with trisomy 18? Exomphalos, yes? Gastroschisis normally are not associated with chromosomal defects, or not trisomies anyway. Okay. Good. Kidneys and bladder, so we keep coming down. So we've seen our umbilical cord insertion. In fact, it's still there, the umbilical cord insertion. And here is the bladder here. And these are the kidneys, yes? Cross-section through the kidneys, spine at the top, nice kidneys on both sides. You can see a normal kidney here, normal brightness of the kidney, little bit of fluid in the renal pelvis, and you see both kidneys on both sides. So in order to make sure that your kidney is normal, you see them laterally to the spine. They're just posterior to the stomach. And you can see this normal tissue, which is quite similar to the bowel. So the kidneys can be sometimes a little bit difficult to see, especially in the early second trimester. And the cortex is nice and homogeneous, so it's all the same color roughly. And the renal pelvis is here. If you measured them, if you measured that distance, there would be less than 7 millimeters at about 20 weeks of gestation. And if you look at the bladder, you see the bladder, it's centrally positioned in the pelvis, it's in front of the rectum. It's a thin-walled structure, it's got nothing inside, and the size of the bladder varies quite a lot. So sometimes the bladder is tiny, sometimes the bladder is quite big. That's because the baby has a pea inside, then it goes down, and then it fills up again. It should always be just below the size of the umbilical cord insertion. If it's above that, then it's probably quite big. Then you should wait and see if it empties. And if it doesn't, there may be an obstruction. And either side of the bladder is the umbilical artery. So if I put color onto this image, I would see the umbilical artery on each side. And here we have dilatation. What is this called? This is bilateral hydronephrosis. So I have a little bit of extra fluid on both sides of the kidneys. Here it's on one side of the kidney. And here this is a longitudinal cross-section of the baby. That's the head of the baby there. I don't know if you can see that. It's the spine of the baby. You have the bladder here, and you can see how big the bladder is. This is a condition called megacystis, and is usually due to obstruction in the urethra. And the point here is that if it's an obstructive picture, everything above the obstruction becomes dilated. So when you have dilatation, it depends on where the obstruction is and whether it's unilateral or bilateral. And importantly here, and in general, is to assess the amniotic fluid. And this is a general point, not just for obstruction, that you need to look at the amniotic fluid as part of your structural scan. But in particular, with urinary tract obstruction, you need to make sure that there is normal fluid around the baby. Okay, and just a few more images here, which I won't dwell on because of time. Good. So, just to summarize, the key to identifying anomalies in babies is to understand what the normal appearance is. So there is no better thing to do than to do lots of normal scans. When we, all of us, when we start ultrasound, we want to see the exciting abnormal cases. But actually, it's really important that you scan lots and lots of normal cases, because there is variation within normal, and you need to make sure that you familiarize yourself with what normal looks like. It's important to have a consistent approach to scanning. No fishing is allowed. I always say to my clinical fellows, no fishing. You know what you want to see, you go and see it. Okay? So have a consistent approach. Don't scan randomly. Start in one place, know where you're going, you know where you're moving, you know where the baby's lying because you've imagined yourself lying there. Find the long axis of the baby and assess the appearances. Look at the baby in a consistent approach using a cross sections through the baby. Head, face, chest, abdomen, urinary tract, all the way to the bottom. Just slide your probe from top to bottom. And in order to go to the femur length, you usually need to take a slightly different approach and move to the coronal. And look for the major abnormalities that we need to look for, in particular the cord insertion, the kidneys, the bladder, the spine, and the beating heart, as well as, of course, the head and the abdomen, which you will get for free by taking the measurements. And I think that's it. Thank you very much.